afterwards, and we did have notice from 3 or 4 people that they weren't able to attend, so we'll be able to share this with them. To start, I just want to say we're very excited to host the CRC Talks with Max Kleijberg. He's a visiting scholar from Sweden, and we've had the honor of working with him over the last number of years, and he feels like a good friend and a wonderful part of our family now. So when we started talking to him about having him share his knowledge with us when he came for this visit, we felt particularly drawn to this topic and the importance of it. Before we begin, I'd like to acknowledge that I'm a visitor from the traditional territory, or I'm a visitor to the traditional territories of the Algonquin people, and I'm from Nunatuhuvut. I have a deep appreciation for the Songhees, Esquimalt, and Wasanich nations on whose territories the University of Victoria stands. Also, in the spirit of respect and reciprocity, I would like to acknowledge the territories and homelands of the original and current caregivers of the many lands and waters we live. May we all strive to understand and reframe our responsibilities for untying the knots of colonialism. And I invite everyone to join us on this journey towards reconciliation. May we be guided by the principle that embracing diversity enriches all of our lives and helps us to understand each other and our responsibilities for creating an equitable and inclusive community. I'm going to pass it over to Max. He's going to introduce himself and we shall go from there. Thank you for joining us.
Great. Thank you so much, Karen, for this. I'm going to start sharing my screen and we'll start the slideshow. You see the slides and not my notes, do you? Great. I'm going to move things around a little bit on my screen so I can see everything that I need to see. Okay, great. Yes, thanks again for having me. So the title of the talk today is Peer Advisors Promote Cancer Prevention and Early Detection, Experiences from Sweden. And what I'm going to talk today about is basically a recently published paper that you can access through the QR code if you're interested in that. So I'm originally from the Netherlands, but I've lived in Sweden since the past 13 years. My background is in design and art, but I have a PhD in healthcare science. And so this means that my research is often transdisciplinary and also action and change oriented. I'm a researcher at Karolinska Institutet, which is a medical university, maybe known for the Nobel Prize. And so my research is taking a health promotion and equity approach to issues such as aging, severe illness, and end-of-life care. And I also work a part of my time at the Regional Cancer Center Stockholm Gotland. So that's why the logo of the region of Stockholm is on here. And that is basically where this project is based. So I will tell you a bit more about that. So a little bit of the presentation outline. Before I start explaining that, I will show in this presentation some pictures of peer advisors, like the one that I showed on the slide before. They were taken a number of years back to promote the work of the peer advisors. So they're not taken in relation to this research. And I will also show some of the quotes from the data, and they're anonymized. And for some of the slides, I just didn't have a good illustration or picture or quote. So then I just added photos of some of my sailing adventures in the Stockholm archipelago from last summer. I really love sailing, and this is our little sailing boat that I share with a friend of mine. And I know that in some countries it's sort of upper class to have a sailing boat, but in Sweden, people really make efforts to make it accessible. And Sweden has the most islands of any country in the world, so it's really amazing to go out sailing and just explore. So the presentation outline, I will just talk a little bit about the background of this project and also just share a little bit about Sweden. the regional cancer center, Stockholm, Gotland, that I work at, and then go on to explain the peer advisor project, and then how that relates to the research project that I will share some of the findings of. And then I hope that we can have some time for discussion together also. So yeah, Sweden is right here. I don't know if you can see my cursor, but it's in the north of Europe. This is a map with Swedish names. So Sverige is Sweden. And it should not be confused with Switzerland. Some people confuse that sort of Sweden or Switzerland, but Switzerland is in the middle of Europe. And we have a campaign going on. There's this company that's called Visit Sweden, that is government owned, that's sort of promoting people to visit Sweden. So they have this like genius, I think, a current campaign that's called Welcome to Sweden, not Switzerland. So you can go and check that out. They explain the differences between the two countries. So healthcare in Sweden, a little bit of background on that, is largely tax funded. And then we have the National Board of Health and Welfare, which is a governmental agency under the Ministry of Health and Social Affairs. And this is compiling information and also develops standards to ensure good health, social welfare, and high quality health and social care for the whole population. But healthcare is decentralized. So on this map, you see the 21 different regions that I think are comparable to maybe the provinces in Canada. And so they use what they get orders from the National Board of Health and Welfare to apply that in the local context of the regions. But then the municipalities, and we have 290 of them across Sweden, are also responsible for a part of that. So, for example, elder care and home care is a responsibility of the municipalities. So we have both public and private providers of healthcare. And so the same regulations apply to both. So when regional councils buy services from private healthcare providers, it is based on a model where the healthcare is financed by the council, but carried out by the private provider. Something that I also wanted to mention was 1177, which is a website, but also a phone number that helps patients to navigate the healthcare system. And it's also a point of information about diagnosis and healthcare services. And this is a collaboration between the 21 regional councils. And it's the main tool used by the healthcare system to disseminate information. So there are 6 regional cancer centers that work together with the regions to organize cancer care. So here you see on this map which regions are and municipalities are involved in these regional cancer centers. And so they have these cancer centers have 3 main assignments. And it is to work on cancer prevention and early detection. So for example, screening. And it's also to work on treatment evaluation and quality registries, and also develop and design cancer care processes and programs to minimize waiting times for patients, but also work on equity in cancer care. So there's this national cancer strategy document that is supported by politicians. So it's developed by the collaboration of these regional cancer centers and then signed off by politicians. So we really have a political mandate to work on everything that is written in the strategy. And then each cancer center also has their own regional cancer plan that are also signed off by regional politicians. So I am working for the Regional Cancer Center Stockholm Gotland, and that's the green area here. So Stockholm is the most densely populated region in Sweden, and then Gotland is the smallest region in Sweden when you think about population size. And that's the island. It's also the island that Putin wants to have. So yeah, but that's another topic. So I'm going to show you this diagram that I am sure you can't read because it's in Swedish and you don't have to read it, but I think the visualization is sort of helpful to understand my work, so where it's placed in this regional cancer center. So on all these horizontal arrows are all the cancer diagnoses. So each cancer diagnosis has their own healthcare program, And then there's people working that are specialized in these diagnoses to make sure that these programs are designed, that it flows well and diminishes waiting times for patients, and also works towards equity. So for example, breast cancer, and then you would go from early detection and screening to treatment, rehabilitation, but also palliative care. So that's all sort of involved in these horizontal lines. So then we have process leaders working for each cancer diagnosis. But then there's also topics that cut across all these diagnoses. So we have, for example, collaboration with patients and their support networks, or primary healthcare, or digitalization. But we also have equity, health equity, or care equity in care. So jämlik vård. What is, I think, interesting to sort of mention in this context is that the word for equality and equity is the same in Swedish, which is sometimes, so that's jämlikhet. And that sometimes makes things difficult to talk about equity because people confuse it with equality. So healthcare providers can sometimes say, oh, but we treat everyone equally. But that's not necessarily the idea of equity. So yes, exactly. And so then I work as a process leader in equity in cancer care. And as you can imagine, there are so many different topics that we can work on. And this is really sort of overwhelming when I started a little bit under 2 years ago. The Regional Cancer Center wants me to focus on LGBTQ issues, which I will mention at the end of this presentation. But this project is focused on other types of structural marginalization, particularly facing people with a non-European Union immigration backgrounds. So a little bit more about the region of Stockholm. Here you can see also the municipalities. There's 2.4 million people living there. And we know that there's a higher cancer prevalence and mortality and less screening participation in areas with challenging socioeconomic conditions. So it's kind of important to understand in this context that we really talk about, that we can see that it's about areas, like in certain areas, there's this higher prevalence and less screening participation. So these are often, or actually always, urban areas outside the Stockholm city, which is the capital. So the inside is quite rich and highly developed and has access to all of the healthcare services. But it's the outskirts of the city where the problems, or where there's challenging socioeconomic conditions. People with lower education level, less financial resources, more non-EU immigrants, and also, like I mentioned before, less screening and healthcare services in these areas. So people will have to travel longer times to participate in screening, for example. So back in 2016, way before I started working here, the Regional Cancer Center asked themselves, so how can we address cancer inequities in the region of Stockholm? And they decided to focus on promoting cancer prevention and early detection in these areas with challenging socioeconomic conditions. And they decided to have a peer-to-peer approach, so community-based peer-to-peer approach. And the ideas for this peer advisor project was based on other existing projects. And I think that's also important to mention, because I think as researchers, we often think or assume that everything is based on existing research, but no, this project really came from what my colleagues saw in the field in other regions, what people were doing, and sort of inspired to do that in Stockholm also. But we know that, for example, other kind of peer advisor initiatives in other contexts have helped to increase, for example, screening participation. So we know that from other research also. So a little bit of background on the peer advisor project. Since 2016, there have been 300 peer advisors educated in the region of Stockholm. There's currently 40 active, so they often decide to work for shorter periods of time. And I come back to that later, but it's often also for people who work as a peer advisor. the first job that they will have in Sweden after they arrive as newcomers, and then it's like a jumping board for them to the labor market also. And they're recruited through advertisement and word of mouth. They always speak multiple languages and always have a basic Swedish too, to be able to be a link back to the regional cancer center. They are, of all ages, between 16 and 75 plus, and they're well connected in their communities, or they want to be well connected in their community. So that's the idea. So the Regional Cancer Center, RCC, thought about this project from the start as an information flow from the Regional Cancer Center through the peer advisors to the community. So RCC educates peer advisors who then in turn inform the community about cancer prevention and early detection. So the peer advisors work in shopping centers, squares, public transportation hubs, health cafes, and at libraries, for example, or community events. So if something is happening in the community, then a peer advisor would sort of try and be a part of that, and we'll have like a booth with information. So also language courses. So they often do, for example, workshops as part of state-funded language courses for newcomers. So then the workshop will be about health promotion and so healthy lifestyles to promote cancer prevention and early detection. And so then that's sort of the idea, right? That you can learn the Swedish language through talking about these topics. And they also work in other public spaces. And I'll get back to that a bit later when we talk about the findings. So the education that the peer advisors receive and also the information that then they will go out with in their communities is based on the European Code Against Cancer, which describes research-based recommendations about behaviors and lifestyles that promote cancer prevention and early detection. And so there's 12 points. I will just show 8 of them here. So for example, do not smoke, do not use any form of tobacco, take action to be a healthy body weight, be physically active in everyday life, limit the time you spend sitting, have a healthy diet. If you drink alcohol of any type, limit your intake. Not drinking alcohol is better for cancer prevention. Avoid too much sun, especially for children. Ensure your children take part in vaccination programs for human papillomavirus, HPV. Take part in organized cancer screening programs for bowel cancer, breast cancer, cervical cancer. I have many thoughts about the way that this is formulated and also spread through the European Code Against Cancer, but this is the information that that peer advisors will use in their work, and we can maybe discuss this at the end also. So yeah, exactly. So this information is translated to 12 different languages at least. I think now there's more, and there are peer advisors who speak these languages also. So yeah, what I'm gonna talk with you about from now on is part of an action research project to evaluate and improve the peer advisor project. So as I mentioned, the development of this was not at all part of any research. So now it's really time to sort of start to evaluate the program, the project, and see how we can improve it. And so this will have different stages, and this project is really the first stage where we decided to investigate the perspectives of the people working with the peer advisor project. So that is the peer advisors themselves and also people from the Regional Cancer Center who work with this. And we want their perspectives on the challenges and the strategies they face in their and use in their work, and also their perspective on forms of impact that they think their work has. So this is a qualitative research project, and research participants were 12 peer advisors, and in recruiting them, so of let's say about the around 40 peer advisors that are active, we chose people that really reflect the diversity among the peer advisors, both in terms of background, but also years active and the type of activities that they do in their work, because people work in such different ways. And also 3 representatives from the Regional Cancer Center who really work closely with this. And so researchers, and yeah, I will just, in Sweden, we have this habit of addressing people with their first names. I think that's maybe not the same in North America, but I will just do that here because I think it's nice. Simon is the first author on this article, and he really has an insider perspective because he was working as a peer advisor himself. So I met him first when I interviewed him in the framework of this research project. And during the interview, he said, well, based on my experiences of being a peer advisor, I wanted to become a doctor. So he's now studying to become a doctor and really was interested in being part of the research as a researcher too. So then we were able to hire him formally as a research assistant in the project, and he has done a great work in this. Then there's Lars, who has an outsider perspective. He's the most senior. He's a professor in healthcare science and really has an outsider perspective. And then I was leading this project from the researcher point of view, and had sort of an insider-outsider perspective because I was also, hired by the Regional Cancer Center, so I cannot claim that I have a complete outsider point of view here. So just quickly to go over the roles and what we actually did. The initiators of the project were the representatives from the Regional Cancer Center, and they wanted me to lead it. So the research plan was developed by the Regional Cancer Center together with representatives from the peer advisors and us, the researchers. I led the data generation. I did 15 interviews in total, and also we decided to do participant observations because it felt quite abstract to talk with peer advisors about their work. I really felt that I needed to join them in their work, and that was a really interesting journey for me because I got a crash course in how to be a peer advisor, so that I could sort of help them in their work when needed, because I could obviously not be a fly on the wall in those situations. And it was also interesting because I'm a white guy, and so, for example, Southeast Asian women could be concerned about, we are going to inform people about cervical screening and HPV vaccination. How's that going to go when you're there? So I did a lot of pre-work to understand how I could be in certain situations. So if you're interested in that, we can talk about that also at the end of the presentation. So analysis was led by the researchers. So mainly Simon and I did this together with Lars in a collaboration. And we had regular meetings with the research participants to talk about preliminary findings and see if we were on the right track. And then the writing of the article was led by us. And I thought this was also important that, for example, the Regional Cancer Center representatives were not part of writing it up, because they would obviously have a positive bias on this. And their goal was also to really see what can we improve in this. So we really needed to have to remain a critical approach to this. And then dissemination and knowledge exchange, everyone is involved in this. Actually, this is the first time that I'm presenting this project for an international audience, so that's quite fun. So just to connect to some findings. Findings, we've described them in 3 themes. The first one is about peer advisors acting as a bridge through dialogues. The second theme is peer advisors creating safe spaces for broaching cancer issues, and peer advisors' impact on personal, community, organizational, and societal contexts. So now in the rest of the presentation, I will just go through these 3 themes. So the first theme, peer advisors acting as a bridge through dialogues. Maybe you remember this diagram that the Regional Cancer Center sort of talks about the peer advisor project as a one-directional kind of linear process, But really what we found is that it's more reciprocal than this. Like the peer advisors really talked about and described their work as bridging a gap between cancer care system and communities through creating dialogues. So it's really this two-way dialogue that is really important. So if we zoom in further on this peer advisor community dialogue, peer advisors discussed that communities in which they work, they appear to experience a lack of health and care-related information, and also a need for dialogue with Swedish authorities and healthcare institutions. So, and they also pointed out that this insufficient dialogue can hinder integration of people with migration backgrounds, and then also contribute to health disparities. So they explained that to address these issues, they try and act as a bridge. So one peer advisor said, for example, the community wants to have a dialogue, not just a paper. We try to create a dialogue. A lot of what we do is to talk with people and try to understand, try to get information from them and help them in a way. It helps me to connect. So the paper that this person refers to is, for example, information leaflets based on this European Code Against Cancer. The community doesn't just want that paper shoved in their face, but they want to have more of a dialogue. And so peer advisors are trying to find ways to create that dialogue. So they commonly embed these dialogues in already existing meeting places, organizations, events, and activities, and they often do so on their own initiatives. There's one peer advisor who said, I usually let the coordinator know when there's an event in my neighborhood, a festival, or meetings in the municipality, that there are gatherings of different ethnic groups. Then I tell the organizer that RCC wants to join, and then they'll give us a table. That's how it goes. So with this table, she mentioned that she means to have a booth that is part of these activities. So here it's also really important that to understand that it's often the peer advisors who take the initiatives and to let the regional cancer center know this is happening in my community, and this would be really helpful for us to be at this place because the regional cancer center doesn't have this knowledge. Yeah, so this quote really illustrates also the importance of the peer advisors have with community-based connections on like both personal, organizational, and municipal levels. Yeah, so peer advisors create their own spaces for community dialogues through using their own interests, skills, and networks. So, for example, there is this retired person that is working as a peer advisor who is really interested in book clubs and really wanted to use a book club format to promote cancer prevention and early detection. And this other person, during the COVID-19 pandemic, of course, people couldn't really do in-person health promotion activities. So she decided she thought I'm good at, in creating virtual spaces, meeting places. So she decided to do like language cafes, virtual language cafes during the COVID-19 pandemic. Yeah, so this dialogue increased the peer advisor's understanding of community needs. So questions that come up regularly that the peer advisors talk to me about in the community were questions regarding HPV vaccination and screening, the process of mammography screening, like how does that go and who does that to me? And also difficulties understanding letters of invitation to screening. So people would literally also bring this letter to peer advisors to say, what is this about? I don't recognize this. Like from my home country, we don't have these things. So what is this about? And so then also the dialogue with the regional cancer center is really important. So if we zoom in on that a little bit more, the peer advisors would communicate with the regional cancer center about community needs. Sorry, I have to take a sip. Also, the education that the peer advisor receive from the regional cancer center is a part of that. And then also through this dialogue, the regional cancer center will improve materials and also education to address the community needs, basically. So one example of this feedback took place during the early months of the COVID-19 pandemic, as it became clear that people living in areas where the peer advisors were active sorry, were overrepresented in illness and mortality rates. So RCC representatives recommended the Stockholm regional healthcare authorities that peer advisors could be asked to inform about COVID-19. Sorry, I'm losing my voice. Instead of cancer for the time being. Oh, wow. Sorry. So one regional cancer center representative said, the coordinator had a lot of information for us, which we would never have been able to capture otherwise. So that was awesome, I thought. She was so much knowledge about what works and what does not work, and she hears what is being talked about on the street right now. And here it's important that this regional cancer center representative is talking about the coordinator. So the coordinator is a peer advisor who really is the link in this dialogue between the regional cancer center and the peer advisors. So the coordinator is really coordinating the peer advisors' work and also the link with the regional cancer center. And is therefore playing this key role in this dialogue. So when discussing the peer advisor RCC dialogue with representatives from the regional cancer center in interviews, they seemed also critical and discussed opportunities for improvement in this dialogue. As, for example, illustrated in this quote, an RCC representative says, sometimes I think we work too little systematically. It's about the connection between us at RCC and the peer advisors. This direct contact, we would need to tighten that, because then I think we would improve the project even more. Their work should be more integrated in RCC's other work. I think we would benefit from that. Yeah, and I think this is really one of the major improvement findings, that we need to tighten that dialogue with peer advisors to have a more direct and systematic dialogue. So the second theme is sort of describing the overarching strategy for establishing and maintaining community dialogues regarding cancer prevention and early detection. Is to continuously adapt to various forms of diversity with the intention to create safe spaces for broaching cancer issues. So I'll just go shortly through these three different themes or topics. So it is evident from both interview data and the observations that the peer advisors commonly adapt their approaches to diversity among communities they work with. So in terms of diversity in ethnic, cultural, and socioeconomic backgrounds, and also people of different ages, genders, experiences, and perceived needs. And then there's also this diversity in the context that they work in, right? So different neighborhoods will have different contexts, different types of events that they are a part of, interacting with people on the street, sort of more one-on-one or in group activities, such as in the language cafes, and also different seasons and times is, of course, also diversity in context. So one peer advisor said, often you're in areas where people have worse socioeconomic backgrounds, and there can be a different kind of cultural atmosphere in those neighborhoods, a different kind of interacting. So you should adapt a little depending on where you are. It's kind of illustrating this adapting to the various forms of diversity. So then, to determine appropriate strategies for broaching dialogues about cancer, the peer advisors seem to combine their first impressions of people. So their first impressions of the people they encounter with their knowledge about the diversity of the contexts in which they work and their own unique experiences and perspectives and knowledge. So, for example, I think this is best illustrated by this quote. This peer advisor says, I add things up. I connect various things. For example, this person, I can see that she is shy, and then I approach her and begin to talk. Hi, how are you? In her language. Eventually, she'll tell me things. Then I tell her what I know, what I want to help with. It's important that you don't disturb people. They come from a different country that doesn't have democracy or has war the whole time. Women don't have rights like here in Sweden. They're shy. They're afraid too. So that's why they need extra explanation. So I think this quote really beautifully also illustrates why there's this need for extra efforts in this target group. And also I think it's just beautiful how this person is talking about adding things up, like her own background with the perceived background of the person and the context that they're in. So I think this is something that is difficult to teach, and that's why it's, I think, also important that to work with people in the communities. I think a common challenge peer advisor described was about navigating culturally based sensitivities related to cancer. So, for example, a fear of the disease or a sense of shame in living with cancer and or participating in mammography or HPV screening. And then peer advisors commonly reflected on using their own knowledge of their own cultures to find ways of discussing these issues. So they often talked about being an insider, that helped. Like the person from the previous quote also said, she's an insider, so she can have a good connection. But then there was also this one peer advisor who pointed out that sometimes being an outsider also helps, particularly if it's about a sense of shame around it within the own community, that as an outsider you could actually also become a point of trust. So some peer advisors so an overall strategy that we found was also sort of a funnel strategy, which means to not directly start talking about cancer, but start to talk about health in general, and then through conversation and dialogue, finally talk about cancer. And this person says, I don't immediately say cancer because people distance themselves. Then you need to slowly approach the topic and say that there are different illnesses and that you need to take care of yourself, that there are different methods, like with food and exercise, all kinds of things. Among other things, it's cancer. So then there's the intention to create safe spaces for dialogues. And establishing a sense of trust is really important. Like this person says, I give myself, like I'm your friend, you can trust me, no one will know. And I've met many women, and their trust is important. And then I asked, how do you create that trust? And she said, often I have met those women many times, not just once. They are active in the same association as I am. So this person is talking about creating sense through confidentiality, shared characteristics, having experience with this work, pre-existing relationships, community connections. But then there's also people who talk about creating trust through consistency. So being in the same spot every week, for example, so people recognize you, and also just social interactions about other things than cancer. Yeah, I'm just gonna hop this over this quote. Like, one challenge is really being perceived as a salesperson, as you can maybe see on this photo. And so people really use their social skills to address this, to make clear they're not there to sell anything. I also just want to mention this kind of innovative way of creating safe spaces, which is through Zumba. So is this kind of dance-based training that they offer, just like it's like a pop-up thing in shopping malls, and people can just join, and it's really fun to watch and be a part of it. So one person said, so then the idea is to offer this Zumba class and then afterwards talk about cancer prevention and early detection, which I think was so fascinating. And then one peer advisor said, everyone appreciated and stayed after the class and started to talk with each other. We had a group with just women, and we informed about HPV, self-testing, and mammography, and they had questions. And the men who were on the other side, they had questions about how can you quit smoking, those type of things. So it was a very successful activity. And I think this was one of the participant observations that I did. And it's really interesting to see how through dance you suddenly become a group, and it becomes sort of safer to talk with each other about these more sensitive issues. I thought was fascinating. Yeah, so the last theme that I just want to quickly touch upon describes the peer advisors' impact on personal, community, organizational, and societal contexts from their own perspectives. So in relation to personal community contexts, peer advisors talked about feeling a sense of meaning themselves doing this work, being able to help other people, integrating in society themselves, and also a sense of community among peer advisors. One person said, for example, when I started, I worked with a woman from Morocco. She was almost Swedish because she came to Sweden as a child, so she spoke Swedish very well. I learned so much from her, not only the language, but also practical things. I asked, how do you do things in Sweden? Because as a foreign woman, I didn't know much. She was very kind. We became friends. People also talked about that this was their first job in Sweden, that it helped strengthening their resume and getting new jobs. But they also talked about lacking insights into, okay, what's the impact on the community? Actually, we know that we inform, but we don't know what does the community do with this. So that's a limitation. On an organizational and societal context, so within RCC, there seems to be an increased awareness for equity in cancer care. They've adjusted the regional cancer plan based on findings from this. And there's indications of increased screening participations in the area where these people work, but we really have to do more research to understand that better. And also there's a potential beyond just the cancer topic. For example, they informed about COVID-19 during the first pandemic waves. They've been an important resource for us. Another example has been with the war in Ukraine. I immediately called the coordinator. Do you have peer advisors who speak Ukrainian and Russian? Yes, absolutely, she said, and found a few who could help in welcoming refugees. So people talk about that this should be implemented more broadly than just about cancer. And peer advisors also talk about having limited insights in these forms of impact as well. So I also just want to touch upon, before we open up for questions, sustainability and structural challenges that limit the impact. So of course, there's financial, managerial, and political support needed to do this project. And there's needed a transition from that this is a project that is sort of still run since 2016 as a pilot project to really become an established program on a regional level. We have not found yet an existing managerial structure that could do this at the regional level. And then also peer advisors talk about structural challenges upholding inequities. And I just want to mention this quote where this person says, it's hard for, peer advisor says, it's hard for people who are new in Sweden to enter the labor market. It's a complex problem, partly because of a naivety about it, because it can be difficult for those who are born and raised in Sweden to understand how it is for those who came to Sweden and start from zero. To create good systems, that's so important. Besides information about health, it's about keeping people away from criminality and giving them a good education and good conditions. And then you have a kind of naivety about this problem. It will show on many levels, all the way up to us peer advisors, when we try to reach out with vital information, for example, about how important it is for women to participate in mammography. So yeah, we can discuss this also, I think. So I just want to sort of end with, again, this diagram, the importance of dialogue that is really facilitated by the peer advisors. That we have knowledge gaps about what the long-term community effects are, how does the community perceive peer advisors, and how can the Regional Cancer Center actually strengthen the dialogue with the peer advisors. I think I will stop there and open up for questions. I will also stop sharing so I can see you.
Thank you, Max. That was fantastic. I have so many questions. I have pages of notes written down. Does anybody, Amber, did you want to start us off?
Oh, sure. I was just clapping, but I will start off with a question. I guess that one of the first questions I have is this pilot project, like, is there an end date to the pilot, or is this kind of an ongoing project until it becomes kind of a core part of the cancer control plan?
Yeah, so this is a good question and hard to explain because I find it hard to understand myself as well. But the regional cancer center is actually not supposed to do these kind of projects or like host these kind of projects. They're supposed to develop it and implement it. But this project really showed that there's no structure on a regional level where this could be implemented. So that needs to happen. And we hope that based on this research, we could also highlight that for local politicians to create these structures. And so we are on our way, and that's also one reason why we do this project. And so that's why it's formally called like a pilot project, but it's been running for all these years. Politicians really find this important and have been funding it all this time. So, and it's also described in the strategic cancer plan, which is then backed up by politicians. So yeah, it's both a pilot project, but also there's some structural support for this, which makes it like, yeah, a complex issue.
Tara, thank you for that. Amber, does that answer your question?
Yes.
Okay, perfect. Tara, did you want to go next?
Thanks for that awesome presentation, Max. Just fascinating work. And I think you started to sort of address my question at the end of your presentation and then with Amber's question. But so it sounds like there isn't, a sustainable sort of person or manager or role that within the regional cancer center that works with the peer advisors. But how did that component function, or does it, for the project portion of it? So I guess my question is, who are the peer advisors linking in with at the regional cancer center, and what is that person's role?
Yeah, so that's the coordinator, and
Okay.
the coordinator started out as a peer advisor herself. So the project was developed by someone like me working with equity in cancer care. And then when the first year happened, and then this person was recruited to actually be hired on by the regional cancer center on what's it called?
Like a term?
It's not a job position. It's like how do you say, a freelance person, sort of
Okay, like a
hired.
contractor.
Yeah, exactly, like a contractor. Which I think is also a problem because this person doesn't know if next year she can still do this job. Until now, it has been happening all this time, but they cannot create a job position for her, and I think that's a problem, like a structural problem. Then we have, I think, another problem is that everything is so siloed. So, for example, now cancer, we work with cancer. Then, for example, we have this multicultural center that's on a regional level where I think it would fit, but that has been like really hard somehow to embed this there. So
Thank you. Yeah, I'm just curious on the cancer center and what that piece looks like, and how it's working or not working. So thanks.
yeah.
Thank you, Tara. Tina, did you want to ask your question?
Yeah, picking part deeper into the same theme of the previous two questions. So my thought was, I'm trying to understand, is there no other established volunteer program within the cancer system? Like, is this a brand new first attempt at volunteerism?
That's a really interesting question about volunteerism. In Sweden, there's no tradition of volunteering in the healthcare sector at all.
Okay.
So I do a lot of work in palliative care, where in the rest of Europe, for example, and palliative care will be really like even based on volunteers. There's not at all the case in Sweden. We have volunteers in every other sector, but not in healthcare. And I think it's because there's this big tradition of the state takes care of healthcare.
Right.
We should not have to take care of that ourselves. So that's an issue. And I also should mention that they're not really volunteers because they get paid for the hours that they work.
Okay. So
Yeah.
it's not an issue of the Sweden being not a culture of volunteerism. That's just a particular sector it hasn't been a
Exactly.
part of.
Yes.
And in the
Yes.
palliative side, where it exists, does it fit in under the compassionate communities model? That idea that it doesn't need to be necessarily formalized volunteer programs, but more just a part of everyone's, you know, way of contributing to community. Is that?
Yeah. So
Yeah.
the other, I mean, now we're getting into my other
Yeah.
projects actually. The other issue that we have there is that, I mean, yes, we work with compassionate community, sort of the underlying ideas for that,
Yeah.
but we cannot really use the same terminology because there's not really a word for community in Swedish. Which doesn't mean that there's no community.
Yeah.
No sense of community, but it's
Yeah.
just we have to use other language, and also compassion is like hard to translate. So we work with the ideas, but not necessarily with those terms. Yeah.
Okay. Thank you.
That's great. I have a couple of questions. One is around the peer workers, who supports them, and how do they cope and manage with these really intimate relationships with people, and and then how do those relationships translate into a healthcare service when they're now working with a provider, and they go from intensive, caring, warm interactions to maybe something that's a little bit more scheduled and just different. What that looks
Okay.
like.
So the point of this is really that they are working on the prevention side, right? So I actually was also interested in this is another topic. So they're trying to, what I also found, and that's maybe not as much through in the article or the presentation, is that people sometimes really do get intimate relationships with the people that they inform about cancer prevention and early detection, because then people will, for example, talk about, oh, but I got diagnosed with this. Can you help me? And also, Tara, we talked about navigating the healthcare system. So people really ask for that. Can you help me navigate the healthcare system? So for me, that would sort of be the next step, to go not only from cancer prevention and early detection to navigating the healthcare system and also into end-of-life care. And I've asked about that in the interviews, but a lot of them, some of them said that of the peer advice said that they would be interested in that, but a lot of them actually said that they are so happy to just have like a positive view on cancer, that you can actually help to prevent it. And also detect it early. And your other question also was about their support. I mean, that's the piece about the community, that they really feel among themselves, that they really get support from each other in this. But there have been some interactions where I felt like, wow, this is maybe going very far, that you have given your phone number to this person, for example, and now this person cannot stop, it's just asking you about all kinds of things. So some people find it difficult with boundaries. Also because, you're informing in the neighborhood where you live. So even when you're not clocked in, people can still recognize you. So that's also a challenging piece for sure.
Interesting. And then my other question was about funding. And given this can be a conduit, or sounds like a really powerful conduit to employment and maybe financial stability, or different type of financial opportunities, who then is that included? So you mentioned politicians fund the program, but does that include like employment and development? And is there opportunity, like, is it a gateway to that kind of?
What do you mean with the development?
Well, like the Ministry of Employment. Does the Ministry of Employment recognize the importance of this kind of beginner job, or something like you were saying? This can be an opportunity for new immigrants, or people new to Sweden, to get engaged in skill development.
That's fascinating. I haven't even thought of that. That's such a great idea. Yeah. And I think that's also one thing, is that it's the regional cancer center is so siloed into only thinking about like the healthcare thing. But if we want to also go the route of employment, because this is really, really a strong thing of this project, that a lot of people have gotten great jobs based off that they could show that they have experience on the Swedish market, and so that's actually a great idea.
Yeah. Okay, Tina, did you have another question?
Oh, sorry, no, I put my hand on, although I'll add to what you were just saying. So in a previous life, I worked for 10 years with BC Cancer, so the provincial cancer clinics here in British Columbia, as a manager of volunteers. And you're absolutely right. We tracked that about 40% of our volunteers annually were transitioning into the workforce because of their experience with volunteerism. I like to joke that I'm going to be able to call in a lot of favors for future physicians that I helped to get into med school, for example. So that is a good route to go, is to show that connection. And sometimes that can be, if the cancer centers are, teaching institutions, to really lean into that as well. That it's another avenue that, yes, they bring on students through residencies or through placement through the university or the medical schools and nursing schools, but before they even get into that, they often start as volunteers, and work their way through, or in your case, a nominally paid peer support program.
That's fascinating. I'll bring that back to Sweden.
Wonderful. Well, thank you so much. Does anybody else have a question before we sign off? Okay, we frequently hold CRC Talk, so if you're on our mailing list, you'll get notified of those. I know Ashley usually puts a link in the chat, but unfortunately I don't have that. So, but please visit us or email me. I'm learn@uvic.ca, and thank you so much. Take care. Bye, everybody.
Thanks so much for hosting. Thank you.
Yeah, thanks, Max.